There are multiple developments in therapies for chronic lymphocytic leukemia that are occurring today. There are developments in the area of targeted therapies with non-covalent BTK inhibitors such as pirtobrutinib and nemtabrutinib. There are also novel classes of agents being investigated among targeted therapies, such as cyclin-dependent kinase 9 inhibitors. There are several drugs in that space. There's also a very promising class of drugs called BTK degraders. Those drugs are designed to target Bruton tyrosine kinase, which is also being targeted by covalent or non-covalent BTK inhibitors. However, they are not true kinase inhibitors. They actually harness the kinase and process it for degradation. So the mechanism of action is very different than standard kinase inhibitors. Very exciting, promising class of agents. There are also multiple developments in immunotherapy with chimeric antigen receptor T cells recently being published data in CLL with very promising overall response rate of 80% and progression-free survival of about a year and a half, including in patients who are refractory to both ibrutinib and venetoclax. And in that space also a class of emerging agents is bispecific antibodies. The bispecific antibodies have been approved in therapy of non-Hodgkin lymphoma in Europe, in follicular lymphoma specifically, and we are expecting that hopefully we will have access to these agents in the United States. But in CLL they have been developed a bit slower, but trials of epcoritamab and mosunetuzumab, the two bispecific antibodies, are now ongoing in chronic lymphocytic leukemia. And then another exciting field is natural killer CAR cells, which have so far limited data, but the data that we see is very encouraging with essentially very limited side effect profile, very favorable side effect profile, and initial high efficacy in chronic lymphocytic leukemia. Okay. Yeah, so the challenges essentially have emerged with the introduction of new agents. So one of the challenging patient populations is now what we call double refractory patients, so patients who progressed both on BTK inhibitor and venetoclax, and there are really no truly FDA-approved drugs in that space. So those agents become good candidates for clinical trials with one of the agents I just mentioned. But still, this remains an unmet medical need. Patients with deletion 17p or p53 mutations are also patients who unfortunately do not respond as well to current targeted therapies. So whereas in patients who receive venetoclax and venetuzumab in frontline setting, the median progression-free survival in CLL14 study has not yet been reached, but patients with deletion 17p have median progression-free survival of less than 50 months. So those patients already started progressing. So they remain an unmet medical need. And also BTK inhibitors do not work as well as for the non-deletion 17p group of patients. So those patients are still ones who, if they're younger, are considered for allogeneic stem cell transplant. And that's really for these patients we need to develop new therapies as well. Well, I think there is a lot of exciting developments in the field. We are trying to move towards time-limited therapies. Of course, venetoclax and CD20 antibody combination is an example of approved time-limited therapy in CLL. However, there are multiple efforts to combine BTK inhibitors and venetoclax as a time-limited therapy. There are multiple studies ongoing, such as Captivate, GLOW, MAGIC trial, which that's an example of a trial which combines acalabrutinib and venetoclax. And it would be very exciting to see whether a combination of BTK inhibitor and BCL2 inhibitor in frontline setting results in improved progression-free survival, maybe even overall survival, then sequential therapy. This would be an all-oral combination therapy, so certainly a very exciting development. in the field, and we are waiting for this data. And the development of novel agents that I have just mentioned is also very exciting. I think we will have an ever-expanding armamentarium of drugs for patients with CLL, and the field, probably the landscape will shift again in 5-7 years, just like it changed completely 3-4 years ago, with essentially full disappearance of chemotherapy in treatment of CLL.